Good afternoon, everybody, and welcome to today's webinar. I'm Winnie Teo, and I'm from Group Clinical Education, welcoming you on behalf of the Institute for Humanistic Medicine, or HUME, as we know it in NHG, to our Humanity at the Heart of Healthcare, or what we like to call the H3 webinar series. And as we continue our journey today towards more person-centered care at NHG, we are privileged to host a dialogue between two clinical leaders who have dedicated their careers to the evolution of the patient-clinician partnership. Now, our keynote speaker today is Professor Glyn Elwyn. Professor Elwyn is a world-renowned authority on shared decision-making, SDM, from Dartmouth. And he has over 30 years of experience as a clinician and researcher. Now, Prof. Elwyn has been the driving force behind the global adoption of tools in SDM, such as the tree talk model, things that many of us use to navigate complex clinical conversations. And today he will share his insights on how we implement SDM across the world, what he sees are opportunities and challenges. And he will draw from his work across multiple international healthcare systems. Now, joining us today as our discussant is our very own Associate Professor Tang Wern Ee, who is also a very dear friend. As a senior consultant family physician and director of the clinical research unit at NHG Polyclinics, Wern Ee brings a wealth of local expertise in health literacy, chronic disease management, and health services research. In addition, her master's in health professions education makes her uniquely qualified as clinician, researcher, and educator to discuss how we can translate global SDM frameworks into the practical day-to-day realities of our local primary care and clinical settings. So together, Prof. Elwyn and Dr. Tang Wern Ee will explore how we can bridge the gap between global theory and local practice. So welcome everybody to this webinar. Some housekeeping matters first of all. So we will have Prof. Elwyn share his slides after this. And after that, I will invite Wern Ee to give her response as our clinician discussant. For the participants here who are joining us, do put in your questions and comments in the chat. The chat button is found at the top banner of your screen. During the Q&A, we have a Q&A session that probably begins about 1:30. We will have about 20 minutes after Prof. Elwyn gives his talk and after Wern Ee gives her comments for your questions. So put in your questions as they come. I will take a look at your questions in the chat and I will bring them to our speaker and discussant. All right, and do stay on till the end of the webinar to give us your feedback because we'd like to know what other topics you'd like to see in future H3 webinars. So without further ado, could I welcome Prof. Elwyn to take the mic and start us on our sharing. Prof. Elwyn?
Well, thank you, Winnie. Thank you very much for the invitation here. Thanks to the Hume Institute and the NHG College. Let me share my slides and I will get going 1 second. So I've been asked to talk about shared decision-making, opportunities and challenges. So as you can see, I am a clinician, but I've been doing quite a lot of work in this area over the last few years. Let me start with a little bit more of an introduction as to who am I. I want to just give you some very sketchy background about myself. So I didn't start in medicine, actually. I started studying Welsh literature in North Wales, and I did medicine. And I've had associations with different universities, as you can see, but I've also worked not only in Wales as a family doctor, but then a little bit in Africa. And then more recently, I've spent the last 10 years at Dartmouth College in the United States. So that's me, a mixture, if you like, of somebody from the humanities originally, but then who went into medicine and found that I was really interested in patient-centered care. So I'm going to share where I'm from. This, when I look out from the farm where I grew up in North Wales, was one of the mountains I could see. It's called 𝗛𝗲𝗹𝘁𝗵, a very tough mountain. Many people in winter lose their lives here because they are unprepared for the ice and snow. So I'm from a very mountainous country, at least in the north of Wales. But I want to show you, first of all, a cartoon that a friend of mine drew many years ago. This is a cartoon of a medical visit. And I ask, when I show this cartoon, I want you to imagine yourself in a medical visit, and I want you to imagine yourself putting words in that speech bubble. What is this man saying, do you think? Let me pause there and ask you to maybe think about the phrase that he's saying. I ask audiences to speak out as to what might he be saying. And the kind of responses I get is, well, I have your results here, or I have some bad news for you, or I want to give you more information about your diagnosis. And that's a natural reaction, I think. Most people think that the man in the glasses who's pointing at this piece of paper is the clinician or the doctor or the health professional. And then I show the second slide. And I say to the audience, as I'm saying to you now, this is not the clinician. This is the patient speaking. And most people are a little bit surprised. They didn't make that assumption. They thought it was the clinician. And then I ask a much more difficult question, which is, what did the doctor say or do that helped this man say those 4 words? I prefer this option. And you know, that's a more difficult question, because it looks as if she's not doing very much. But what she's done, of course, is that she's given this man enough information about options so that he's formed a view about what he prefers. She gave him some information probably on this piece of paper. But she also did more than that. She asked him a question as to what does he prefer or what does he think. And she paused and she went quiet. She went quiet for long enough for him to be able to say, I prefer this option. And you know, that may sound easy, but I think this is a difficult skill to achieve. I say to audiences that this clinician who is quiet and her body language is like waiting, she probably created something we call psychological safety. This man felt safe enough and capable enough to say, I prefer this option. And I often say to audiences, as I said to people here in Singapore, if I only had 2 slides to tell you about shared decision-making, these would be the 2 slides. If you in your practice can get to a situation where patients feel comfortable and confident to say, thank you for that information, I now understand the pros and the cons and the harms and the benefits, and this is what I think I prefer, you have achieved shared decision-making. So let me give you what I think is as simple a definition as I can imagine. It's a collaboration between individuals. And by that individuals, I mean the patient, and also, if necessary, their family, their friends, their next of kin, that blends science, good science, really good science, evidence-based medicine, if you like, with clinical experience, the experience of the clinician, what they have to bring to the table, and also this idea of patients' or people's preferences. Preferences that I hope are informed by science and by clinical experience. And so to compare options or plans, it could be things that we might do next, like order a test or have a plan for a behavior change. These are the kind of things that are the next steps in any clinical encounter. So this is the definition. And I'm showing you a recent paper that Paul Gudbranson and myself published in the journal General Internal Medicine. Let me go on to give you a little bit more detail about what I mean by shared decision making. So I'm going into a little bit more detail of the paper itself. Before I do that, though, let me use this metaphor of that mountain. This is Michael Barry and Susan 𝗔𝗵𝗿𝗁, a patient actually, writing in the New England Journal of Medicine and saying that shared decision making is the pinnacle of patient-centered care. Patient-centered care was a phrase that came along in the 70s. And here we are saying that actually the very best aspect of patient-centered care is to involve patients and to respect them and to hear their views. But this requires skill, and it requires clinicians to invite people and then to say to them, I'm going to support you to come to a really good decision here. I'm going to tell you that there are reasonable options in this situation, and I'm going to encourage you to tell me what you think about these options. This invitation is really important, and I think clinicians need to be explicit about this so that people feel comfortable about the process of being involved in decisions. People will naturally be a little bit uncomfortable about this new responsibility. And so I really admire the work of Timothy Quill, an ethicist, who said, you should not abandon people to make difficult decisions on their own. They will need a lot of support and maybe even guidance. This idea of not abandoning people to tough decisions is really important. It also involves respecting patients wanting to talk to other people. They will have family members, a partner, friends, relatives, and they will want to talk to others. And this means that trying to do this in a hurry or just in one visit might be very difficult. Of course, there are circumstances where you have to make a decision quickly, but most decisions in medicine allow a little bit of time for people to talk to other people. And this, I think, is really important in a culture like in Asia, where people have strong ties to their families. It really helps, I think, to understand what's important to people. We call these goals, and there are 3 levels of goals. Goals about symptoms. I have a headache. I want to get rid of my headache. That's the symptom level. And then a goal around function. You know, I have this headache and I can't concentrate. I can't do my work. So that's a problem. I can't do my work. That's the functional goal level. And then there's a deeper goal. And this is what it's interesting for clinicians to find out. Okay, so you've got a headache. You can't do your work. But what's a more deeper goal? Well, actually, it's because I can't do my work, I can't pass my exam, I'm not going to get promoted, and so on. That's a deeper life goal, a fundamental goal. And those goals are really important in a clinician and a patient working together to decide which options shall we put on the table. We call that goal elicitation. And of course, here's the difficult bit. This requires, if you're going to compare options, really good information. Not just, accurate information, but trustworthy information. And not just good information, but information that patients can understand and understand pretty quickly. And to design information that people from different literacy levels, maybe who are not good at reading or are from a different culture, designing that information with pictures, maybe even with video, in a ways that people can understand easily, is actually quite difficult. And here's the idea where we've been designing patient, as they call, patient decision aids, or other comparison tools to help people make sense of the information about treatment options. And the last step of all, when people have understood and have had time to think about the information. Let's ask you what you think about this information. We call this perspective elicitation, where you help people arrive or maybe think they need more time to defer the decision. It involves dialogue, it involves listening, asking more questions, asking about people's emotions, fears, priorities, and so on. And always saying, we don't have to make a decision today, maybe. We can come back to it after you've had time to talk to other people. So putting all this together, this is shared decision-making. We called it a primer for clinicians. And if you are teaching or if you plan to teach shared decision-making, I recommend you think about all these steps. Another way to think about it in a slightly simpler way, especially if you're teaching maybe undergraduates or early residents or people in the early postgraduate years, is to think about it this way. Winnie mentioned this 3-talk model. And the first kind of talk is about making a team. Let's work as a team, work together to make a decision that suits you best. That's the kind of phrase you would use there. Number 2, option talk. Let's compare these different options in a way that you can understand. And I'll pause so that you can ask me questions about them. And then the final bit of talk. Tell me what matters most to you about this decision talk. This sounds very simple, but it's not that easy to do in a situation where you might be under time pressure. So this, I think, is a reasonable simplification of the process, but to do it well, I think, is a little bit more complicated. I'm going to move now to ask the question, okay, so this sounds okay. I mean, who would argue against the idea of sharing a decision with patients? And I'm going to ask a really important question here as to who benefits? Who benefits from you doing this? Well, we already know from the last 20 years of research that patients benefit. They really do. I think this is not controversial. Patients seem very satisfied when this is done well, when people feel supported, not abandoned, to say, I'm trying to make the decision that fits best with your circumstances. So patient satisfaction scores go up. There's no doubt about that. Their knowledge about treatment choices goes up. They know more about the risk of harms and the probability of benefits. There's no doubt about that. Especially if you're using tools like this one, for example, which we designed a few years ago, an option grid where you compare in a very easy way the different treatments using frequently asked questions. What does the treatment involve? Are there any side effects? What are the risks, and so on? So these tools, there are many trials now, over 200 trials of these kinds of tools, showing that patients really benefit. And not just patients, clinicians also benefit, because if you're early in your career, they give you very good evidence about the comparison of these different treatments. I think they give patients immunity against regret. Inevitably in healthcare, even choosing the best treatment, things don't go right always. Things go wrong. You have bad outcomes. Even though you're treating your blood pressure, a stroke might happen. And so, but if you've explained to people that there are possibly risks or side effects or adverse outcomes, at least patients know about them and their families know about them, so that you build up an immunity against people saying, well, I didn't know this could happen. Why didn't you tell me that this could happen? I call that immunity against regret. Patients trust you more if you're honest about treatment options and the possibility of benefit and the possibility of harm. And increasing trust reduces patient anxiety. There are improved individual outcomes. If people understand their treatment and they are willing to adhere to it, they comply to the treatments much better. And we already have some existing evidence, particularly in asthma and diabetes, that people's individual outcomes improve. And of course, this translates into improved population level outcomes, biomedical outcomes, never mind the affective or psychological benefit that I've already mentioned. In some situations, there are cost reductions, but I don't think it's a good idea to argue in favor of shared decision-making just to reduce cost. It happens in some situations where people say, well, thank you for explaining the possibility of that surgery and how complex it is and so on, but I think I'll wait, thank you. In other words, whether you have over-treatment or overuse of certain procedures, then there might be cost reductions. But this is not the goal of shared decision-making. The goal is not to reduce cost exactly, but to do what's in the patient's best interests. And if you explain to them what's in their best interests and they decide with you, maybe cost reductions will follow. Here's an interesting benefit. People will complain less if you've told them already what might happen, and they're not surprised. There will be lower litigation, legal costs, and this is highly relevant in a place like the United States. Now I'm going to pause a little bit to say those are the benefits for the patients. Who else benefits is an important question. And in a recent paper, published, I think, about a year ago now, or maybe slightly less, I asked this question: where's the return on investment for clinicians? Because I don't think it's fair to say that this is easy work or it doesn't take a little bit more time. If you do it well, I think it is going to take a little bit more time. But there's a return on investment. And, we asked people who are doing shared decision-making day in, day out. We asked 24 doctors across the world, 12 in North America, 10 in Europe, 1 in South America, and sadly, only 1 in Asia, but we should have asked more. But maybe we can come to you here and ask you whether you think you could benefit here. But these were 24 doctors who were champions of shared decision-making. They had been in real-life clinical practice, and they still were. Some of them, most of them actually, over 10 years as clinicians. And I list below there which specialties they were in. And as you can see, they worked across different specialties. What they said to a person, actually, nobody disagreed with this, and they all said the same thing. They said that doing shared decision-making brought professional fulfillment to them and well-being. I was really surprised about this, and I kind of kicked myself for not having asked this question much earlier in my career. They said they had lower risk of moral injury, of doing things to patients that were against their own values. And because of that, they felt at much lower risk of burnout. And I thought, this is really quite important. If I'm hearing this from clinicians who've decided to become really committed to do shared decision-making, maybe there's benefit for other doctors too who pick this up. They also said that it created better teamwork. They showed shared decision-making skills to their team, and their team felt we are part of a really high-quality performance team here. So, just to summarize, the clinicians who were doing shared decision-making day in, day out for many years said they had better self-esteem, better professional fulfillment, reduced risk of burnout. And because they shared decisions, they felt a shared responsibility So if bad things happened, they didn't feel so responsible or so bad. So let me just summarize this then. If you really embrace shared decision-making, where do the benefits go? Well, I already said, patients benefit. We've got uncontroversial evidence of that. But here's another line of research, and more people need to do similar research to this in different contexts. Here are a list of the good things that seem to happen to professionals who do this day in, day out. And then I stopped to think about, if this happens to clinicians, maybe the organizations in which they work also benefit. Because if you've got less burnout in your clinical staff, then you have less people going off sick, less people deciding not to work anymore, lower complaints, enhanced reputation, more patient satisfaction scores, never mind the better clinical outcomes, and even possibly higher incomes for the organizations. So how do we get this done? What are the challenges? Well, there are many challenges. I've been here in Singapore for the last 3 days. Winnie and Aaron have been putting courses together. So I'm going to suggest to you that these are the people that you need to talk to about how to get shared decision-making done. We've left them with many papers, many ideas, and they convened a wonderful workshop. I don't know, about 40 or 50 people here in NHG who were learning about shared decision-making, how to get it done. And we gave examples of hospitals in Germany and in Denmark and some in the US who are doing this day in, day out. I don't pretend it's easy. It involves leadership at departmental level, but also at executive levels. The chief execs and the chief financial officers need to get behind this. But it also means that you as a clinician need to embrace this way of working. So please get in touch with Aaron and Winnie and say, okay, can you help us here do this shared decision-making in Singapore? Can we measure it? Well, I think we can begin to measure shared decision-making. So let me ask you some questions now. I want you to imagine the last visit that you had to a clinician, you or a family member. And I want you to score this question I give it to you on the way out the door. How much effort was made to help you understand your health issues? If there was no effort made by the clinician, you give them a score of 0. If it couldn't have been better, you give it a score of 9. So can you just jot it down now in your head? Where are you on this scale? Are you somewhere near 0? Or are you somewhere near 9 or somewhere in between? Score it now. Then I'm going to ask you a second question. How much effort was made to listen to the things that matter most to you about your health issues? 0? Or was it every effort was made? Score it now. The last question, how much effort was made to include what matters most to you in choosing what to do next? Score this one as well. 0 if nobody asked you or tried to include what matters most. 9 if they really did this. And these 3 questions cover the 3 big areas of shared decision-making: giving you information, asking you about your preferences, and then including your preferences in the decision. So now I want you to add those scores up. I wonder if you could write in the chat right now, is anybody got a score of 27, which is the maximum possible score? Winnie, I want you to just watch the chat and tell me when we're finished if there's anybody giving a score of 27.
Sure, I'll do that. I haven't seen anything yet.
We have, I don't know how many people we have on the webinar.
I have over 250 people, Prof.
Okay, all right. So then I ask the next question. If we were to ask 100 patients, how many of that 100 patients would give a score of 27? And, you know, when I ask this question to audiences, people say, oh, maybe not many, maybe 1%, 5%, something like that. So they don't think that patients would give a score of 27. And then I tell them, you know, your patients are much more generous to you than you imagine. The score for most patients who answer these three questions is 64%. And most people are very surprised at this. But here's the interesting bit, that this score can vary depending on the clinic and depending on the doctor or the health professional. It can go as low as 40. It can go as high as 85 or 90. So we can begin to measure whether patients feel they've been involved in shared decision-making. If you're at the average, you'll score somewhere at 64%. If you're below average, you'll be in the 40s. If you're really doing well, you'll be in the 80s or 90s. So we can begin to measure this. And even more exciting than this, as you know, we are getting to the situation where clinical encounters are being recorded and the transcripts are arriving so that you can have a summary that goes in the computer. We can probably measure the degree to which you're giving people choices and information about options in the clinical encounter using that recording. So around the corner, maybe in a few years, we can accurately calculate how much shared decision-making is happening in your clinical visit.
Yeah. Prof, I'm going to just pause you there for a moment because we do have a few responses in. You're right, nobody has done 25 or up to 27. We do have a scattering, mostly ranging from 22 at the highest end, and I do have a 6, and most of them seem to cluster around 15 to 16.
Yes.
Yeah.
Well, this is the normal kind of scoring we get. And it's interesting, right? People are really hard. They score this very low, but patients score it very high. But even if they score it high, we call this 27 the top score, and we can find variation by using the top score. So where do you want to find out more? I'm going to pause now, Minnie. I'm almost at the end here. Is there extra reading you can do? Absolutely. There's lots of papers about this. There's also this book, the Oxford Textbook of Shared Decision-Making, which I did with Natalie Joseph-Williams and my colleague Adrian Edwards from Cardiff. And in July this year, we've got a conference in Dartmouth called A Wider Lens. About, I don't know, I hope 300 people come and talk about shared decision-making, where we now are, the contributions of the artificial intelligence to this field and so on. So these are my details, Winnie, if anybody wants to get in touch with me. So I've come to the end now because I'd love to have a conversation with people about what I've just shared.
All right. Thanks very much, Prof. Elwyn. Dr. Tang Wern Ee. Hi, Wern Ee. Thanks. So we can have a conversation now, 3 of us. Yeah. Welcome, Wern Ee. Hi.
Thank you. Thanks for the invite.
Yeah. So glad to have had Wern Ee with us on the EOEP. So audiences, as you know, yes, Prof. Elwyn has been with us for the past 3 days, and Wern Ee has been learning with us and talking to Prof. Elwyn as well. Now, Prof. Elwyn, I'm just going to start off with this question, which I'm sure you've heard many times in probably every country that you visit, and was probably the top of our minds when we first met you, right, this week. And translating SDM into clinical practice, I'm sure you've heard that, you know, Prof. Elwyn, I don't have enough time in a 10-minute consultation for this. What does the literature say about, you know, time and SDM?
Yeah, it's a really important question. I don't think we've done good enough research on this, honestly, because the research is showing that only it adds a couple of minutes. But I don't trust the research, Winnie. Because
what's missing?
I think if you do this well, it takes quite a bit of time, actually, because people, as soon as they hear and understand that there's a tough choice, they want to think about it and they want to talk to their friends and families. So I think what we really should be thinking about, what's the process, not just a single encounter, what's the process? How many visits do we need in order to get to a really good decision? Starting people on an antihypertensive or a statin drug is not something you have to do urgently. You can have a couple of conversations about it. It's an important decision because you're going to be on that drug for many years, maybe your lifetime. So the answer to your question is, I think if we do this well, it will increase slightly the time that you have with patients. I happen to think that's a good thing, and our managers should allow us more time.
Okay, thanks, Prof. Elwyn. And now we turn to Wern Ee because she's the clinician on the ground in NHG polyclinics, which is like, it's been described, right, primary care Wern Ee, as a real pressure cooker, and it's high volume every day from the time your clinic's open. And yesterday you were just telling Prof. Elwyn, the clinic is supposed to stop operating at a certain time, but oftentimes your clinicians have to stay beyond that because you don't turn patients away. So given this high volume setting, how do you see SDM playing out? And if you were convinced about the advantages of health of SDM, how would you as an individual clinician help to put that into a polyclinic setting?
Yeah, thanks. Just to say, thanks, Winnie, for inviting me for this. And it's been really, really wonderful having the chance to interact with the participants at the workshops, as well as definitely Prof. Elwyn. So learning a lot. So I would say, and I think my, thanks for saying that, for recognizing that actually SDM does take more time, because I think in the literature, there's been something that, well, it's actually, but we on the ground, the clinicians really feel that it will be taking more time. And I think some have mentioned the workshops that it may open up Pandora's box when you ask things like that, and it prolongs the primary care consult. And because in primary care and for family physicians, really it's very broad, right? We cover every system, every age group, etc. And so there is that very real fear that this would consult would never end, because there just new things will just keep coming up. But when I was reflecting a lot about what you've been seeing over the past few days, what I think is that perhaps as a starting point, it would be actually to perhaps think of how this can be seen in in what is currently being pushed out by the Ministry of Health, our 𝗛𝗲𝗿𝗁 SG, where we actually have patients being choosing a primary care provider. So it could be a GP, it could be a polyclinic, but staying with that primary care provider, at least where possible. And that one of the things that the family physician would have to do, the family doctor would have to do really, is to do a health plan with the patient once a year. So I think perhaps, and we do actually have a consult for that health plan. And so I think maybe that's where we could be a starting point, where that at least in that particular consult, when we're discussing health plan, that we have elements of shared decision making, which is communication with patients, really finding out what matters to them, because in terms of the chronic conditions and perhaps at least that shared goal, we do target setting and all that. So perhaps then that could be a starting point for it. And I think probably for it to be more widely adopted, I think realistically, I think there would probably need to be certain system changes, so that it could be more widely done. And that's when I was just wondering, Prof. Elwyn, if you could think of the various places that you have seen in the world that has had success in it. What do you think would be some of the system changes that we could actually think about or work towards?
Right. Thank you. I think you're absolutely right that setting that relationship with the patient as they join your practice could be a really good place. It's almost like forming a contract, right? This is the way that I work. I'm going to share information with you. I'm going to involve you. So that's a great idea. I do think that there are ways to maximize the efficiency of comparing treatment choices, especially if you already know the diagnosis. And in primary care, you sometimes know the diagnosis before the visit, but often you don't. So you may have to have the advantage that primary care gives you, which is a longitudinal relationship, right? You see this person more than once. And so you can say, hey, we have this diagnosis today. I want to give you some really good information about the treatment choices. I would love you to take this information home with you, and also that you discuss it with your family members, so that when you see me again in a week or 2 weeks, you are in a better place to have a discussion with me about these choices. So using tools like this, conversation starters or conversation preparation tools, to get that patient into a place of being better informed. Now, you may have to do that yourself in the visit, but there are really good tools available that help you do that information exchange. And that will increase your efficiency, because in some primary care practices in the United States, they're using decision coaches or nurse practitioners that give these tools to patients before they see the clinician for a decision or a prescription. So those are some of the ways forward here. But I think the major benefit for a family doctor like you is that you have a longitudinal relationship.
Would you have any advice also for, because I think in public healthcare in Singapore, the patients may not be able to choose their provider. So for us, it's for this Healthier SG is a relatively newer construct that we're starting out on. But I think in public health institutions and like in the hospitals and all that, when they get even in the follow-ups in the specialist outpatient clinics, and they may not be able to choose their provider, which means it may be a different provider each time they come, maybe a certain setting. Would you have any thoughts about how that could be, some of these system challenges could be overcome, or some mitigating things?
You're asking more difficult question every time.
I do apologize. Yeah.
That's such a difficult situation if you have no continuity, right? You have a new clinician every time. So I think in that situation, you have to rest on the longitudinal record, what's in the EHR, the electronic healthcare record. And I hope that these records will get better at describing what you did. So if the patient has seen you last week and now they're seeing me, that I have a good record of what you discussed with them, what options you gave them, what tool you gave them, so that I can pick up where you left off. Sadly, I don't think these electronic records are that good. One of the things, and I think we discussed in the workshop, that is happening at great speed at the moment is this idea of ambient recording, and you getting a good summary of the visit put into the record. And maybe the quality of the electronic health record will help you have more continuity of the decision-making process. I gave you the tool. The next visit will be about deliberation and asking your views about your treatment options. So I live in hope, but I think you are describing a very difficult situation.
I wonder, Prof. Elwyn, because you've visited healthcare institutions around the world, surely this has been something that's inherent in I'm not sure, in a number of these institutions, where there is, especially in acute care settings, where each time you come in, you are faced with a different provider.
It's true, but I have a very nice example from an emergency department in Texas, actually. And in an emergency department, you only see that patient once, right? They come in with an emergency. What they did, actually, is they took that 3-talk diagram and they made the big poster of it, and they put it on the wall of the emergency department, or in every room, actually. And the training of the clinicians involved talking to them about the poster, the team talk, the option talk, and the decision talk. And the reaction that the clinical leader, the director of the department, got from the doctors were, hey, why are you doing this? Why are you putting these posters up? Why are you telling us about shared decision-making? We already do this, they said. We already do this. And the director said to them, well, you may well be already doing it, although he had a question mark over that, but you may well be doing it, but does your patient know that you are doing it? In other words, are you being explicit about it? I am going to share a decision with you. I'm going to give you good information because I want to hear your views. And the doctor said, oh, fair question. I don't think I'm explicit about it to my patients. I'm not telling my patients that I am trying to involve them. And that made all the difference, actually. And what the emergency department doctors have found in this small hospital in Texas is that their patients are much happier. The number of people being discharged against medical advice is much lower. So they've got a better relationship with their patients, even in the short 10 to 15 minutes that they have in the emergency department. So although it might sound idealistic or very difficult, building that trust quickly with the patient and asking them about their goals is a way to maximizing the efficiency of your practice.
All right. Thanks, Prof. Elwyn. Yeah, I was going to ask, are there settings where you think SDM would be less prevalent or less needed, I think? And the answer sounds like, well, wherever it can be implemented, whether in principle or whether the whole model is there, it does bring benefits both to the patients as well as to the healthcare providers. Now, thank you. For Wern Ee, I was just thinking, because Prof was mentioning that, patients do want to know that they are being consulted, and patients benefit when it's made explicit that the doctors are sharing the decision with them. And I was thinking, for Wern Ee, in Singapore, a significant portion of our patient population may be elderly. And for these people, they may have lower health literacy, or they may be a culturally rooted mindset that, okay, I come to you, you're the doctor, and you know best. How do you think that, there are ways that we need to adapt Prof. Elwyn's SDM models to our local Singapore population that has a lower health literacy and tends to be a bit more passive?
So I think one of the things that I've learned over the past few days with Prof. Elwyn is that actually it's really the SDM is very much a communication technique. It's how do you actually communicate with patients so that you build trust, and then so you can elicit also what their preferred options are. And perhaps sometimes it's the framing of this, right? That it's really what are your preferred, what matters to you really. And so perhaps it's maybe in the way of framing. So because I was thinking back to some of the patients who we had when we actually give them an option and they say, well, you're the doctor, you decide, kind of thing, right? But perhaps a better way in which I could have framed that discussion was, could you tell me what matters to you? And therefore working from that, then would I then say that if this matters to you, then these are how this would relate to what matters to you. And so it's the framing of the options so that it's in the context of what matters to them. Because I think the patients may defer to the doctor for the best treatment option, but I think we can always, encourage the patients to tell us because they are the experts in what matters to them, and I don't think they will defer that because they will know what what matters to them. So I think perhaps it's to frame that conversation with the patients. Because I think when we say shared decision making in our local context, sometimes we're not that familiar with those terminologies, and but at the crux of the thing, I think it's really about are the decisions being made sort of like in sync with what matters to patients. And so perhaps it's to bring that conversation back to the patient, regardless of their health literacy levels, to say, could you tell me more about, what matters to you? But of course, then there's the time taken to actually do all that, which is a conversation altogether. But I think in terms of actually approaching this, I mean, that's what I was thinking about. I'm not sure. What would Prof. Elwyn's view be on this?
Completely agree with you.
Okay, thanks.
Okay.
Completely agree with you. And framing that as I am interested to hear your views, that's the very correct way to frame this.
Yeah, thank you. Yeah, so it sounds like, it's not really so much about, the decision point per se, but it is always about eliciting preferences. And people do have their values and their preferences, right? No matter their level of health literacy, no matter what their mindset towards, recognizing the doctor as the expert is. And I think, Wern Ee, you framed it very nicely, that it is about finding more about the patients themselves. I do have some questions here in the chat. Great. I see two questions, quite similar. So I'm going to kind of just roll them into one. And this is something that I was planning to bring to you all, which is about healthcare being delivered in interprofessional and multi-professional teams nowadays, right? And SDM, primarily, we've been thinking about it as a dyadic interaction between the doctor and the patient, or just between the healthcare provider and the patient. Now, what about a multidisciplinary team? Surely shared decision-making means that there has to be this level of understanding that's shared between, let's say, the different healthcare professionals, right?
Well,
could we apply the same model then, Prof. Elwyn?
Absolutely. I think there's an amazing opportunity here, because often within teams you get conflict actually about, oh, well, this clinician over here does that, and this one over here has that idea. And what I've noticed, there's a cardiologist that we spoke to in that study that I mentioned, who gives the work of providing the information about the treatment options, whether it's a new aortic valve or a Watchman device, for atrial fibrillation. She gives that work to her nurses in the clinic. And so they do the work of preparing the patient about what's involved, what are the choices. And so by the time they see the cardiologist, they already are very well informed, and they've already kind of have an idea of which way they want to go. So the time the cardiologist takes with the patients is reduced, actually. And her team members feel very much empowered and on the same page as the cardiologist. So everybody feels part of the process, from the receptionist to the coach to the nurse practitioner to the cardiologist. So it creates team cohesion, actually, if you use these tools, these comparison tables, as a way of, what do we say to our patients? Are we all agreed that we're saying the same thing about the treatment options? So it creates a very good functional team. But we've only just started to experiment with this approach of preparing patients. And so we have got very little evidence so far of the improvement in team cohesion. But I think it's a good research question.
Okay, so it seems that the model can be applied to the healthcare team, even without or before the patient comes to the table, right? And Wern Ee, I just wonder how, whether you have thoughts about that, seeing that, in the polyclinic, there is coordination of care, right? And that for a lot of the family physicians, the coordination of care really becomes one of their biggest roles.
Yeah, so I think definitely, I think where possible, it would be best to hear from the patient themselves, or the spokesperson, to about their care. So I was just reading the chat about the question from I think it's 𝗵𝗵𝗻. It's actually about, it sounds like what happens if the patient is absent, right? And that care is being discussed about the care for the patient in a MDT, multidisciplinary team discussion, for instance.
Yeah.
So I think ideally there should be a patient advocate there, and I guess one of it, again, we're back to how can we improve our electronic health records, right? So that it can record down in terms of patient preferences with regards to whatever it is aspect of care that needs to be discussed. So so that in terms of, at least from the SDM, and as the team is deliberating through through options without the patient being present, it's sort of like the next best thing, I guess, is to at least have someone. So I think in some cases it could be like the medical social worker, who could be the patient advocate. But at least there's something in the records, the health records that people could refer to just check in to see whether that's aligned. Yeah, just some thoughts about that.
I think this is a very good question. These multidisciplinary teams, I've been in many of them, especially where you've got a complex cancer or a complex multi-morbidity patient and so on. And what's really interesting is that the clinicians in that team often have different views about what's best for the patients, right? So they are debating treatment A versus treatment B versus treatment C. Should we use radiology or chemotherapy? And it seems to me that this is a wonderful opportunity to bring the patient voice into that discussion. It's not just a professional discussion. The patient and their family would have preferences. And I've seen cases in ear, nose, and throat cancer where somebody is losing their voice box or losing their tongue, where people have very strong opinions about what they want, and yet their voice is not in the room. So there's a glorious opportunity, maybe not to have the patient there to hear these clinicians, arguing about what's best, but at least somebody should be eliciting their preferences and putting that into the multidisciplinary team conversation. So that's a very good opportunity for improving care, in my view.
Yeah, I was just reminded about my experience. I had a few years ago conducted an observational study in a diabetic foot clinic, and Prof Elwyn, I did tell you about it the other day, where the patient would be sitting with the podiatrist, who would take about half an hour, and in that time, in that same clinic, there would be the endocrinologist come in to give their recommendations about titrating the medicines. And then there would be a vascular surgeon, because oftentimes, there would be foot care implications for that, as well as surgical complications of previous surgeries. And I thought, that time really was a multidisciplinary team meeting together with the patient. I'm just thinking that was like a real life in-person MDT. But if you're thinking about option grids, they were doing option grid kind of a decision, right? Option grid discussion there in that room because the patient was there. And I'm thinking the option grids has been designed mainly to give patients, to help patients decide, okay, which option would I want to choose, right? But in a case where patients with chronic disease, they're usually facing multiple morbidities and all that, handling multiple decisions about different diseases. How have option grids evolved to meet these sort of increasingly complex changes?
They haven't.
So how?
They have not. I mean, and that's where you need really skilled clinicians to say, okay, you've got heart failure, you've got diabetes, maybe a bit of COPD. That's so complicated, and you need doctors like Wern Ee to be able to navigate that, because I don't think it's possible to create an option grid that handles that complexity. It's too much. Even with artificial intelligence, I don't think we can do that. So that's where you need a very skilled, experienced clinician to say, what's the route through these multiple problems? So I am not advocating that tools like this are good enough on their own, not at all.
So I like to say that actually there is the promise of AI, and I think there are attempts to actually build decision support systems that takes into account multi-morbidity, because I think even the best of us in doing general medicine or general practice or family medicine would actually have face challenges with our increasingly very complex patients.
Yep.
So I think there is that promise of AI, which we hope will materialize. So we look forward to that. Yeah. But I
agree with you. And as I get older, I hope that maybe there will be a solution there.
I think one of the things also is at the end of the day is really back to the patients, right? To how to say that I think for patients, most of them, they know what they want in life, in the sense of the quality of life, or in terms of, you know, the number of pills that they want to take and all that. But I think it's also to say that that decision has to be revisited over time.
Absolutely.
Because their views change with time, their situation change with time. And I think one of the things that increasingly comes to realize is that it is not a once-off thing. And so even with people with chronic conditions, that having made a decision at a certain time point, I think it's worth revisiting, especially of course when situations change. But even if situations in terms of medically don't change, their home situations may have changed, their perspective of things may have changed. And so I think it is not probably something, not a once-off decision that they make, and it's something I think that we should keep the door open also for them to feel free to actually bring up the issues again.
So it should be an iterative process.
Completely agree with that. Yeah, completely agree with that.
Yeah. I'd like to move the conversation along to something a bit more research oriented, since that's what my day job is. Okay, and it's great because Wern Ee, you are the research director here in NHGP. So from your lens as director of the CRU, the Clinical Research Unit at NHGP, what kind of metrics do you think we should be collecting if we were to try and implement SDM in our institutions? What would you be looking at, Wern Ee?
I think you need a measurement, right? So you need to measure something. So and I think Prof Elwyn's collaborate scale in terms of measuring whether or not SEM was done with patients would be very helpful. And I think it is then also, so I think that would be to see whether or not SDM is done, right? And then I think in order for us to sort of like look at the other outcomes, so I think definitely with regards to, depending on is it a condition that you want to look at to prove the point that, you know, it does improve patients' health outcomes. So then it's I mean, there'll be condition specific, but the sort of like outcomes that you want to measure in terms of health outcomes. I think you have to think about what the health outcomes, and then the other one would be actually about physician satisfaction. All right. So, and it's heartening to know that, you know, it actually reduces burnout, because I think that's a real situation. And I think if we could also measure, you know, what the benefits, we'll measure outcomes that could potentially show benefit for the physicians. So I think that would be great. So I would say for whether or not the SDM is actually done, I would say use the collaborate scale. And then in terms of whether or not it's having a health outcome impact on patients, so depending if it's a condition specific thing that we're looking at, then it's health outcomes. So it could even be like hospitalizations or, you know, duration, length of stay, things like that. In primary care, then it may be healthcare utilization also, but also like it's diabetic 𝗔𝗯𝗃, blood pressure, you know, that kind of thing. So we could potentially measure those. But I'm also very keen to actually also see its impact on the clinician, right? So the burnout scales that various ones that we could have. So yeah, I think it'll be nice if we were to do an evaluation of any kind of any intervention that we do to look at SDM, to actually look at it from the different perspectives.
Yeah. Prof Elwyn, what tips do you have for us if we were to start, trying to implement and then trying to collect data about the implications and the impact of SDM in our institutions?
Right. Well, I think in terms of implementation, what I've learned so far is that it takes a leader or a champion, somebody who is motivated, and to start, and don't have to start very big. But that clinical champion or leader needs to have the support at the departmental level, whoever is the head of the department. And probably what would be really important in the long term is that there's also support at the organizational level, the chief exec or the chief nurse or the chief medical officer, to say, okay, it's an interesting idea. Let's do a pilot. Let's do a small scale. But they are not against it at the higher level, at the executive level. So I would say start with a couple of champions, but they need the support of their department and their senior leadership. So that's the very good place to start.
Yeah.
And then as those people become more skilled and they feel the benefit themselves professionally, then you can start introducing some evaluations. But don't start the evaluation too early because it's quite difficult to start.
All right. Thanks. And I think that's a very good reminder for us, Prof. Elwyn, because I think you probably learned that in Singapore, we just want to do everything really quickly. Yeah. So thank you so much.
Well, I'm happy to help you.
Thank you. Thank you for that offer too. I'm aware of time, so I do want to bring this webinar to a close and thank both our panelists, Prof. Elwyn and Prof. Tang Wern Ee, very, very much. I think for us today, what we've learned, we've learned about the research perspective. We've learned about how SDM can help benefit patients. Thank you for bringing us the data on that, and also for sharing with us that it can benefit healthcare providers as well. I think that's something that is really heartening to hear. And so on behalf of HUME and NHG Health, I want to thank Prof. Glyn Elwyn for his global vision and his work in SDM, and also to Associate Professor Tang Wern Ee. Wern Ee, thank you so much for localizing the knowledge that we have to saying, what can we apply here in our NHG context. And most importantly, thank you for the audience, for all of you, your commitment to placing the person at the center of the clinical encounter. Thank you, all of you.